Hi, my name is Alexander Rabin, and I'm a clinical assistant professor of pulmonary and critical care medicine at the University of Michigan. Today, I'll be speaking about COPD and outdoor air pollution. Objectives of this presentation include understanding the associations between climate change, heat, and COPD, looking at some of the underlying mechanisms by which outdoor air pollution, including particulate matter, contributes to exacerbations of COPD. Discuss some recommendations to help patients with COPD reduce the risk of exacerbations, in particular during wildfire events. And lastly, uh, look at one case study of a way that healthcare providers can reduce their own climate impact. We'll start with a patient presentation. A 65-year-old man with a history of childhood asthma presents to his primary care physician to establish care. He wants to discuss increasingly frequent episodes of shortness of breath, cough, and wheezing that have been occurring, and in particular happened in July of this past year. Before the age of 55, the patient was otherwise pretty healthy. He would regularly exercise outside without any problems. But now he has trouble walking more than a few blocks before having to stop and catch his breath. Other than childhood asthma, he only carries a diagnosis of hypertension. His brother also suffered from severe childhood asthma, and the patient grew up in Los Angeles and currently lives in Northern California, where he works as a high school teacher. Notably, he's currently rebuilding his home with his wife because it was destroyed during the 2018 wildfires. He smokes a pack a day and has been smoking since the age of 25. He does not use any illicit drugs. On physical exam, his vital signs are notable for a low oxygen saturation of 89% while breathing ambient air. His lung exam demonstrates diffusely diminished breath sounds, faint expiratory wheezing up in the apices of the lungs, but no asymmetry or changes on percussion. The remainder of his exam is unremarkable. His flow volume loops, shown here, obtained during routine spirometry, show significant coving of the expiratory limb. Full pulmonary function testing confirms that the patient has severe obstruction with a high total lung capacity and a low normal DLCO, all compatible with a diagnosis of COPD with an emphysema phenotype, and given the low oxygen transfer. This is all compatible with the diagnosis of COPD. So let's step back and talk about what are some of the air pollutants that may predispose patients to COPD and potentially raise their risk of exacerbating that disease. Probably the most important and best studied element of air pollution is particulate matter. Now, this basically these tiny solid and liquid droplets or dust particles that are suspended in the air. The reason they're dangerous is that they can get into our lungs through our mouth or in our nose and travel deep, deep into our respiratory tree. And the smaller the particle is, the deeper it can lodge into our terminal bronchioles, into our small airways, and perhaps even into our alveoli. Now, these particles, these air pollutant components, are divided based upon their size. And so when we talk about PM10, we're really talking about the size of that particle being 10 microns. And you can see how that particle size compares to an average human hair in this diagram taken from the EPA. Now, the smaller particles are known as fine particulate matter, or PM2.5. And then there are also ultrafine particles, which are even smaller, and those are of PM0.1 or 0.1 microns. Now, particulate matter is one of the primary air pollutants that is generated by the burning of fossil fuels, as indicated here. And particulates are dangerous, of course, as mentioned, because they can directly irritate the airways and the small airways in the lung, but they also likely promote inflammation Oxidative stress can lead to immune dysregulation and even affect the very, very delicate airway epithelium. This has been shown in epidemiological studies to increase the prevalence of COPD and also promote acute exacerbation of disease during poor air quality events. But it's not just, of course, the direct effects of particulates from fossil fuels that are of concern, because the burning of fossil fuels, of course, also releases greenhouse gases such as carbon dioxide, which are also heating the globe, and in turn leading to extreme events like wildfires, which again have been very clearly been associated with poor health outcomes from COPD, as well as asthma and other respiratory and cardiovascular diseases. There are also effects from global warming and increased greenhouse gas emissions upon extreme heat events. Heat is an important factor because heat in combination with nitrous oxides and volatile organic compounds, some of which are all released during normal combustion, including from traffic, leads to the production of ground level ozone, which is the primary component of smog. And that again has been shown to worsen outcomes in patients with COPD. Now, there are some modifying factors that may reduce the risk to patients, and these include improved housing quality, better access to air filtration systems and HVAC filters. And of course, there are individual patient factors such as health comorbidities, age, work exposures, whether or not the patient needs to be outside for their employment, and smoking. Now, while air pollution affects everyone, because we, of course, all have to breathe air outside, there is a legacy of inequity that has been clearly associated with worse outcomes in respiratory disease. And one of these is called redlining, which was a policy that dates back to the 1930s, where neighborhoods were zoned according to how desirable or undesirable or hazardous they were considered to be. And the hazardous neighborhoods were literally circled with a red line. Now, as probably it's not hard to imagine, the places that were undesirable ended up housing people who were had less money, less advantaged in society, and had less access to home loans in the more desirable areas. And as a result, for many Black and other immigrant communities who are living in red line districts, those places, even to this day, continue to suffer from worsening environmental impacts, including from air pollution, because they're located near, for example, power plants or big roadways. Nonetheless, the global burden of disease from air pollution is really staggering, and it's estimated that somewhere between 4.5 million deaths a year are attributed just to fine particulate matter pollution. And of COPD, it's estimated that about a quarter of COPD mortality is just a result of ambient PM2.5, or in other words, fine particulate matter that's released from burning fossil fuels, among other sources, of course, including wildfires. As you can see in the chart on the right of the slide, it's also clear, again, as we can see on the more local and regional level with redlining in the United States, that the effects of particulate matter pollution are also not, while they affect us all, are not necessarily distributed equally. And in lower and middle income countries, there are higher burdens of disease. What are some implications for clinical practice? How do we actually deal with this pollution? Well, of course, the bottom line is we need to reduce the amount of fossil fuel combustion. And that's, I think, why it's incumbent upon all healthcare providers to advocate for policies that will minimize climate change and reduce the burning of fossil fuels. But there are also some patient-level factors and patient-level interventions that we really should be thinking about. And these include informing patients to monitor the air quality in their region. And there are excellent websites, including airnow.gov, where patients can have access to their local air quality. We can advise that patients stay indoors when possible and consider use of air filters, including high quality particulate filters like HEPA filters during poor air quality events. Whether or not to limit exercise outside is a bit controversial, but certainly if the air quality is very poor outside, it would be common sense to say that that patient should likely stay inside and exercise indoors if necessary. And lastly, respirator use, which we've seen with COVID, it can be an effective way to prevent particles from getting into the lungs. But again, of course, it depends on the patient's circumstances and whether or not they're able to wear a mask. And for many outdoor workers, it may not be feasible when there's also extreme heat. So for those patients, it's really incumbent upon us all to advocate for policies that will help protect workers. And there are also interventions that we can do in the clinic, and specifically, this is something that I'm interested in as a respiratory care provider, that we can limit the amount of pollution that our care causes and environmental damage. And one of the things that we're looking at is limiting the use of meter dose inhalers, which contain a potent greenhouse gas or a hydrofluorocarbon inside of them. And so for a lot of patients, there are actually good alternatives to these types of inhalers that don't have this greenhouse gas. And here's an example on the right, which is this actually the same drug, Advair, which comes as both a meter dose inhaler as well as a dry powder inhaler that doesn't contain a propellant. So we can try to seize opportunities where there is clinical equivalence in efficacy to potentially substitute. And again, this is an area of active investigation, and of course depends a lot upon local formularies and costs and other factors. But it's one way in which respiratory care providers can potentially reduce the climate impact of their care. Thank you very much.